السلام عليكم اولا، ولازم اتوجه بالشكر للدكتوره غاده ودكتور خالد للدعوه الكريمه وللتنظيم الرائع للمؤتمر. وشرف ليا ان انا اكون معاكم النهارده، وشرف اكبر ان انا اقدم صاحبتي وحبيبتي واستاذتنا في الغدد في الاطفال، استاذ دكتوره رشا طريف. دكتوره رشا طريف علم من اعلام طب الاطفال وسكر وغدد الاطفال. بصراحه لو جيت اقدمها هحتاج وقت طويل جدا. دكتوره رشا رئيس وحده الغدد الصماء في جامعه عين شمس، ورئيس لجنه التعليم والتدريب في الجمعيه الاوروبيه للغدد الصماء في الاطفال، ونائب رئيس الجمعيه العربيه للغدد الصماء والسكر في الاطفال، وعضو استشاري في مجلس الهيئه الامريكيه للغدد الصماء الإكلينيكيه. دكتوره رشا هتمتعنا، واكيد كلكم هتحسوا بالكلام اللي انا بقوله، وهتقدم لنا لكتشر عن Congenital hypothyroidism when time matters.
بسم الله الرحمن الرحيم. صباح الخير على حضراتكم. بشكر حبيبتي وصاحبتي وعشرة العمر أستاذة الدكتورة عبير عبد المقصود على التقديم الجميل كتير عليا، وطبعا أصدقائي الأعزاء دكتورة غادة والدكتور خالد. أنا يعني عضو مؤسس بقيت دلوقتي في ثايرو ايجيبت والإيجيبشن ثايرويد اسوشيشن، ده شيء يشرفني. والجميل في الموضوع ان احنا بنتعلم لما بنبقى ان كونتاكت مع الادلت اندوكرينولوجيستس كتير، والحقيقه الادلت والبيدياتريك بيكملوا بعض، فبتفرق كتير قوي ان احنا collaborating مع بعض وفعلا exchanging our knowledge. هتكلم عن ال congenital hypothyroidism when time matters. Let me open the scene by this impressive trip. These two men taking a trip with their plane and enjoying their time, and this is when you follow the rules. On the other hand, if you do not follow the rules, you're going to crash. And this is what we apply in congenital hypothyroidism. And let me start by the story of this 2-year-old girl who came with midline swelling at the base of the tongue, mild dysphagia, fatigue, weight gain. And neonatal screening for congenital hypothyroidism was normal, but later on when she came, you can see TSH was high, the T4 was low, antibodies negative, and the thyroid gland was not palpable in its normal site. And when we did an ultrasound, there was normally located hypoplastic thyroid with 2 foci of intense uptake at the base of the tongue, the submental area, while the uptake in the thyroid region was very weak. So this is a case of congenital hypothyroidism with dual ectopic thyroid, while the eutopic thyroid was hypoplastic. So the suggested management here is surgical removal of the sublingual thyroid because there were pressure symptom, and the girl started thyroxine therapy. You can see in the table on the right side a very long list of causes of congenital hypothyroidism, and most of cases of primary hypothyroidism, if not all, are diagnosed by neonatal screening, and this is around 90% of the cases with primary hypothyroidism. Thanks God we do not see cretins anymore. It's very rare to see such a condition. And the problem is with the 10% of the secondary congenital hypothyroidism which could be missed by neonatal screening. So the first question, is it primary or secondary hypothyroidism? Is it transient or permanent? Because some cases stop treatment at the age of 3 years. We need to reassess the thyroid axis. So we need to have a treatment plan, because the first question asked to us by the parents, is it a lifelong therapy or not? So we have to answer this question. Permanent congenital hypothyroidism is either due to developmental anomaly like thyroid dysgenesis or dyshormonogenesis or the rare hypothalamo-pituitary disorders. But there is a rising incidence in congenital hypothyroidism. And of course, there are genes associated with congenital hypothyroidism. You can see here the table on the right side, and this is what we already know. This is an old article showing the genes incriminated in ectopy, hypoplasia, and athyreosis. Now, the question, is there any new in the genetics of congenital hypothyroidism? this article published in 2022 showed new genes incriminated in the pathophysiology of congenital hypothyroidism. And in the column on the right, you can see the list of new genes incriminated in congenital hypothyroidism. And even more interesting, is there other congenital anomalies associated with congenital hypothyroidism? You can see here a lot of studies. I'm going to focus on the one from Egypt. And you can see that in Egypt, 70% of cases of congenital hypothyroidism had other congenital anomalies compared to Italy, Brazil, USA, and India. So the message here is don't forget to screen for other congenital anomalies in patients with congenital hypothyroidism. Another 1-month-old male newborn came with right guanal atresia, and this is one of our patients at Ain Shams University. He also had cleft palate. He skipped neonatal screening for congenital hypothyroidism for a reason or another, and then at the age of 1 month, he started to be sleepy with poor feeding. You can see here that the T4 is low, T3 is low, the TSH is above 100, and the ultrasound showed absent thyroid, and the scan showed no tracer uptake. So the next step here is to do genetic testing, because it's not a simple case of congenital hypothyroidism. And this was the result. We identified a new homozygote FOX missense mutation in this boy, and we published this. This is a novel mutation, the first to be detected in this Egyptian boy. This was published in Thyroid Journal. And this is part of a known syndrome called Bamforth-Lazarus syndrome due to FOX1 gene mutation, thyroid dysgenesis, cleft palate, and spiky hair. And another message here is the genetics of congenital hypothyroidism differs between Arabs and Europeans. So I think we need to have our own guidelines, our own genetics. We are different from Europe. Another 10-year-old girl came with a midline swelling, which is cystic, soft, moves on swallowing and protrusion of the tongue. She's asymptomatic regarding thyroid symptoms. Neonatal screening was normal at birth. The TSH was high at the age of 10 years. Remember, she presented at the age of 10 years. And T3 and T4 were normal. The antibodies are negative. So this is a late onset subclinical hypothyroidism. And when we did an ultrasound, we found a thyroglossal cyst. And the thyroid gland was not visualized in the thyroid fossa. The thyroid scan revealed functional ectopic thyroid in the hyoid, and there was ectopic thyroid in the thyroglossal cyst, and this was confirmed by CT because, as you know, thyroglossal cyst containing ectopic thyroid could be pre-malignant. So this is a late onset congenital hypothyroidism, ectopic thyroid inside a thyroglossal cyst and infrahyoid. And in such a case, the management is excision of the thyroglossal cyst because it will be infected and it's pre-malignant, and L-thyroxine treatment. And then we go to thyroid hormone synthesis. It's a very complex multi-step process, and therefore a lot of genes are involved in the thyroid hormone synthesis. And here you can see a novel list of genes involved in dysharmonogenesis published in 2022. Now let's go to the 8-year-old neonate who had a TSH on neonatal screening of 14 while the T4 was normal and the ultrasound is normal. Would you like to treat this child or wait? Who would like to treat this child? Thank you very much. Yes, we will not start. The TSH is still 14. But 2 weeks later, the baby came with a TSH of 22, and the T4 is still normal and the baby is asymptomatic. Treat or wait? Who would like to treat? Can you raise hand? Thank you very much. Yes. If the TSH is of 20, you have to treat. So what's the critical cutoff TSH level to treat? This is when time matters. This is the critical point. Now, based on the article published in JCEM, based on SP guidelines, European Society for Pediatric Endocrine, TSH on neonatal screening above 40, you have to treat. Less than 40, take a venous blood sample. If the free T4 is below the normal or the TSH above 20 or both, you have to treat. And thyroid scan is mandatory if you cannot see the thyroid gland by ultrasound, because you need to know whether it is aplasia or ectopic. If the TSH is in the gray zone from 6 to 20, retest after 2 weeks and do an ultrasound and or a scan. This is European Society guidelines. Now, the controversial zone is the gray zone of a TSH of 6 to 20. In infants with mild subclinical hypo, 72% resolved spontaneously, and indications of treatment if the TSH is above 10, symptoms suggestive of hypothyroidism, or if there is a definite dysgenesis like ectopia. And we have concerns about neurodevelopment and growth. So again, time matters in cases of congenital hypo. Now, this is the latest guidelines on congenital hypothyroidism published by ENDO-ERN in conjunction with European Society for Pediatric Endocrinology. And what did the new guidelines add? First of all, they used the same cutoff, 20. Again, if you have a baby, more than 20 TSH, you have to treat. And you can see on the right side the dosing of T4 based on the age. And it was clearly stated to start LT4 as soon as possible, not later than 2 weeks after birth. What about the monitoring? When to withdraw the sample? Before or at least 4 hours after the last daily dose. We need the TSH to be in the reference range, and we need the free T4 to be in the high normal for growth and development. Now, going to the rare form, central hypothyroidism, again, very long list of genes incriminated in pathology of central hypo, whether isolated or part of panhypopituitarism or part of syndrome. This is a 1-month-old male newborn, non-consanguineous parents. Screening for congenital hypothyroidism was normal because the TSH is not elevated. And this is the tricky point with central hypothyroidism. Then the baby started to have feeding difficulties, hypotonia, sleepiness, and jaundice. And when we did the T4, it was low, the T3 was low, the TSH was low. And the rest of pituitary hormones were normal, so it's isolated central hypothyroidism. MRI brain was normal, thyroid ultrasound was completely normal. So this is isolated central hypothyroidism, and please don't miss it. Think of central hypothyroidism. Genetic testing was done, and we found TSHB gene homozygote mutation in this boy. And by the way, they are controlled on much smaller doses than primary hypothyroidism. And here you can see the diagnostic findings published in 2018 by European Thyroid Association for Central Hypothyroidism. And they raised a very important question. Do we need to add free T4 to screen for congenital hypothyroidism? Who says yes? And who says no? Do you think we need to do this? I think it's important, but the problem is finance. It needs another budget. When financial resources are available, it is recommended to add free T4 to TSH so that you cannot miss the central hypothyroidism. If you have low T4 and the TSH is low or normal or inappropriately elevated in relation to the T4, think of central hypothyroidism. And this was mentioned by ETA Guidelines 2018. Now, going back to the main topic of congenital hypothyroidism, re-evaluation of thyroid axis, we need to answer the question, are we going to continue treatment for life or shall we stop? We need to answer 3 questions: who, how, and when. Who? You're going to re-evaluate those with no definitive diagnosis of permanent congenital hypothyroidism in the first weeks or months of life, particularly if there is normal gland in situ. They have a chance of recovering. How? either you stop over 4 to 6 weeks or you stop abruptly and then you remeasure the free T4 and TSH after 2 weeks. When? At the age of 3 years. Don't do this before 3. Some guidelines stay at the age of 2, but I prefer to do it at 3 for mental development, which is very important. Now, re-evaluation of thyroid axis is not indicated if there is a definite diagnosis of thyroid dysgenesis, dysharmonogenesis by genetic testing, progressive rise in the TSH, and you need to increase the doses of T4. If you have these criteria, continue for life. Do not retest the child. And I think being in an adult meeting, it's very important to highlight transition from pediatric to adult care. It's really challenging, and it's an important part because there is a risk of poor compliance, inadequate follow-up with increased morbidity, educational and social outcome. So we need to collaborate as adult and pediatric endocrinologists to take the transition part safely, and this needs special attention. My final conclusions are: primary congenital hypothyroidism is easy to detect by neonatal screening, but it could present later in childhood with subclinical hypo, and this is very important, don't miss it. Immediate start of correctly dosed T4 treatment at the proper time and follow-up are recommended. Timely assessment of the need to continue treatment and attention for neurodevelopmental outcome in children is really crucial. Harmonization of diagnosis treatment follow-up optimizes the patient outcome. Despite more than 50 years of neonatal screening, some important questions remain, such as the genetic etiology of congenital hypothyroidism, the assumed harm of subclinical hypothyroidism, and why is congenital hypothyroidism increasing in spite of the gland in situ. TSH neonatal screening misses the diagnosis of central hypothyroidism, so please keep it in mind if you have a symptomatic child. The genetic of congenital hypothyroidism differs between Arabs and Europeans. We are different than Europe. And finally, transition from pediatric to adult care is really challenging. And please remember, children with congenital hypothyroidism who are treated early are really clever and charming. I have children who are very, very well as sport people, champions, and very good in education and winners in a lot of things in different aspects. I think that these children really deserve being diagnosed and treated early. It's really challenging to deal with those lovely people as early as possible when time matters. And this is why I called my lecture Time Matters. And I quoted these: success is simple, do what's right, the right way, at the right time. And the bad news is time flies, but the good news is you are the pilot. So once we are the pilots as adult and pediatric endocrinology, it's really important to do it at the proper time. Thank you very much for your attention.